All right, wonderful students. This is the assessment and management of patients with obesity. Excuse me. Obesity is when a body mass index, or BMI, is 30 milligrams per m squared or higher. So approximately 71% of American adults are overweight and 42% of these are obese. This prevalence is higher in women, African Americans, and the Hispanic population. Individuals who have less education and or who earn less income are more likely to have obesity, thus reflecting on the socioeconomic disparities and the disease burden of obesity. Obesity increases the risk for disease, for disorders, low self-esteem, impaired body image, depression, and an overall diminished quality of life. Obesity is a complex disease that occurs when an individual's weight is higher than what is considered healthy for his or her weight and height. Obesity affects children as well as adults. Many factors can contribute to excessive weight gain, including eating patterns, physical activity levels, sleep routines, genetics, social determinants of health, for example, the conditions in which we live, learn, work, play, all of those are called social determinants of health. Genetics, taking certain medications can also play a role. Eating and physical activity patterns, again, insufficient sleep, several other factors help influence excessive weight gain. Genetic changes in human populations occur too slowly to be responsible for the obesity epidemic. Yet, variants in several genes may contribute to obesity by increasing hunger and food intake. Rarely, a specific variant of a single gene causes a clear pattern of inherited obesity within a family. There's a gene called a monogenic obesity gene. It is very rare, though. Excuse me. The conditions in which we live, learn, play, and work, remember we just mentioned it, social determinants of health, that definitely is a factor. It can definitely be difficult to make healthy food choices and get enough physical activity if the social determinants of health affect that, right? If they don't support that type of environment, right? And chronic disease outcomes and risks, including obesity, can be influenced by social determinants of health, right? Other things that can influence obesity include racial, ethnic, socioeconomic groups, as well as different geographies, maybe people with different physical abilities, right? Places such as, are there child care centers or schools or communities, right? And how are these communities affected with the activity, the eating patterns and activity with what foods or drinks are offered, right? And at what cost, right? Because maybe some people can't afford it, right? Other community factors that influence obesity include the affordability of healthy food options. Many times it's, cheaper to eat unhealthy. It could be peer and social supports or the lack thereof. How about marketing? That could definitely impact what kind of community factors are there, right? Definitely politics, right, has a piece of it. All about the community design, right, where these people live, right? And then some illnesses, for example, like Cushing's disease, may lead to obesity or weight gain. Drugs such as steroids, for example, some antidepressants may also cause weight gain. Research continues to look at, the factors that contribute to obesity and the obesity epidemic, right? But we're also looking at other factors like chemical exposures and the role of the microbiome too, right, when it comes to obesity. People who have obesity compared to those with a healthy weight are at an increased risk for many serious diseases and health conditions. In addition, obesity and its associated health problems have a significant economic impact on the U.S. healthcare system. Obesity also affects military readiness. Obesity in children and adults increases the risk for the following health conditions: high blood pressure, high cholesterol, heart disease, type 2 diabetes, breathing problems such as sleep apnea or asthma, joint problems such as osteoarthritis or musculoskeletal discomfort, gallstones, gallbladder disease, a decreased life expectancy by at least 6 years and up to 20 years. They are 10 times more likely to get diabetes type 2 mellitus, 4 times more likely to get hypertension and asthma, 2 times more likely to get Alzheimer's disease. Childhood obesity is also associated with psychological problems such as anxiety and depression, low self-esteem, low self-reporting quality of life, social problems such as bullying and stigmatism, right? In obesity as adults, they have a higher risk for strokes, premature death, mental illness such as clinical depression and anxiety, and many, many types of cancers. Your body mass index, or BMI, has traditionally been used to identify individuals who are the most likely to be overweight or obese. It is calculated by dividing the weight in kilograms by the height in meters squared. So if a patient's overweight, they're considered BMI between 25 to 29.9. Obese is a BMI exceeding 30, up to 39.9. Severe obese or extreme obese is a BMI exceeding 40. Again, hip to waist ratio. So general guidelines to follow during an initial visit are as follows. We want to check the patient's blood pressure, heart rate, fasting glucose, lipid profile that will include their total cholesterol, their triglycerides, their LDL, which is their low density cholesterol, their HDL, high density cholesterol, and then of course the ratio of total cholesterol to HDL. We also look at their HbA1c, or their glycosylated hemoglobin, which looks at their blood sugar for the last 90 days. What did they average? And we also look at their liver function tests. We examine for hyperlipidemia, right? So we're looking for like the xanthelasmata. Ooh, probably just slaughtered that word. That's the cholesterol deposits that are underneath the skin, usually around the eyelid, right? So it's XANTHELASMATA, right? And we're going to screen and evaluate for psychiatric illnesses like depression and binge eating, maybe mood disorders, those kinds of things, right? We're going to try to manage their associated comorbidities. We're going to assess for personal habits and barriers to weight loss. And we're going to evaluate the patient's readiness for weight loss, right? Again, body mass index is a person's weight in kilograms or pounds divided by the square of height in meters or feet. A high BMI can indicate high body fatness. BMI screens for weight categories that may lead to health problems, but it doesn't diagnose the body fatness or health of an individual. So again, a BMI less than 18.5, they have an increased risk of problems associated with poor nutrition. BMI of 25 to 29.9, we consider that overweight. BMI of 30 to 34.9 is considered obese. And then a BMI of 35 or higher is considered significantly obese. Maintaining a healthy weight and BMI has a number of benefits, including but not limited to reducing the risk of heart disease, reducing the risk of diabetes, strokes, high blood pressure. Maintaining a healthy weight can also lower the risk of many types of cancers, can help you feel good, be actively engaged, and more physical. The goal of obesity treatment is to reach and stay within a healthy weight. This improves the patient's overall health and lowers the risk of developing complications related to obesity. The patient will need to work with a team of health professionals, including a dietitian, behavioral counselor, and/or obesity specialist to help them understand and make changes in their eating and activity habits. Obesity management interventions include lifestyle modifications, pharmacological interventions, weight loss, possibly weight loss medications, maybe endoscopic procedures for weight loss, could be weight loss surgery, possibly including adjusting, gastric banding, right? This is an adjustable gastric banding, or maybe it's the full gastric bypass surgery, or maybe it's a partial gastric sleeve. There's other things, maybe not surgery-wise, maybe they're just doing hydrogels or vagal nerve blockages or gastric aspirates. We're going to discuss all of these in the upcoming slides. Dietary changes would include reducing calories, practicing healthier eating habits, cutting calories. So the key to weight loss is reducing how many calories that are taken in daily. A typical amount, a safe caloric decrease would be around 1,200 to 1,500 calories for women and maybe like 1,500 to 1,800 for men, right, to safely lose weight. Another goal is like feeling full on less calories, right? So some foods, for example, desserts, candies, fats, processed foods, all of those contain a lot of calories for a small portion, right? And in contrast, fruits and vegetables provide a larger portion size with fewer calories. So by making smarter choices, we can eat larger portions of healthier foods that have fewer calories, right? Thus reducing the hunger pains that comes along after you eat those, sugary foods that don't have as many quality calories in them. Patient will also feel better about their meal, which contributes to their overall satisfaction feeling, with life in general. So we're going to encourage making healthier choices. So to make their overall diet healthier, they should eat more plant-based foods. This includes like fruits, vegetables, whole grains. And then we want to emphasize lean protein choices like beans, lentils, soy, lean meats, fish. Really, they should try to include fish in their diet a couple times a week. We should also encourage patients to limit the amount of salt and added sugar in their meals. Also to eat small amounts of fats. Make sure they come from heart-healthy sources of fat like olive oil, canola oil, nut oils, those kinds of things. And we really want to educate about restricting certain types of foods. So we want to like high carbs or what we consider full fat foods. They should limit those really. However, patients should ask their providers if these diets are safe for them, right? We don't want to encourage anything until they talk to their provider. Drinking sugar-sweetened beverages is a sure way to consume way more calories than the patient intended, right? So educate them about eliminating, I should say, sweetened beverages. And meal replacements, there are some diets that have meal replacements. So these plans suggest replacing 1 or 2 meals each day with their products that typically have low calorie shakes or meal bars. And then outside of that, they encourage eating healthy snacks, right? And then they have a balanced third meal that's low in fat and calories. In the short term, this type of diet can help individuals lose weight, but these diets likely won't teach the patient how to manage their overall lifestyle. And I think it's important to note that we should be wary of quick fixes, right? So patients may be tempted by fad diets that promise fast and easy weight loss, but the reality is that there are really no magic foods or quick fixes, right? And fad diets may help in the short term, but the long-term results don't appear to be any better than the other diets, right? They simply gain the weight back. Similarly, a patient may lose weight on a crash diet, but they're likely to regain it when they stop that diet, right? And sometimes more weight. They put on more weight than they initially had. So to lose weight and keep it off, patients must adopt a healthy eating habit and lifestyle, right, that they can maintain over time. Exercise and activity. So people with obesity need to get at least 150 minutes a week of moderately intensity physical activity. This can help prevent further weight gain and or maintain the loss of a modest amount of weight. They'll probably need to gradually increase the amount they exercise as their endurance and fitness improves, right? So initially they're not going to be able to do that much, but keep moving. Tell them to keep moving and they'll be able to do more with time. Even though regular aerobic exercise is the most efficient way to burn calories and shed excess weight, any extra movement helps burn calories. So for example, have the patient park farther away from the store entrances or take stairs instead of the elevator. Little things that they could do to help get them moving. Behavioral changes may include counseling and or support groups, right? And a behavioral modification program can help patients make lifestyle changes to lose weight and keep it off. Sleep, getting enough sleep. Again, remember I mentioned in lab, an average a healthy adult needs between 7 and 9 hours of sleep at night. And when a patient, again, the elderly, 6 to 7 hours a night. And when a patient doesn't get enough sleep, it affects the entire body and including the digestive system, right? So again, sleep affects two hormones, leptin and ghrelin, which control feelings of hunger and fullness, right? Leptin tells your brain that you've had enough to eat. Without enough sleep, your brain reduces leptin and raises ghrelin, which is the appetite stimulant. So not only do you not have, the leptin that says, okay, I've had enough to eat, but now we have more of the appetite stimulant ghrelin, right? So we're starving, we don't ever get full when we don't get enough sleep. So you can see how sleep is so important, right? For so many reasons. Thus, getting less sleep increases hunger and it will not get turned off, thus leading to overeating and weight gain. And over time, sleep deficiency will lead to many chronic health problems, including heart disease, kidney disease, high blood pressure, strokes, diabetes, obesity, depression, anxiety, on and on and on and on. Weight loss medications are meant to be used along with diet, exercise, and behavior changes, not instead of them. The most commonly used medications across the U.S. Food and Drug Administration for the treatment of obesity include bupropion, naltrexone or Contrave, orlistat or alizenekal, and semaglutide or Ozempic, right? Some endoscopic procedures for weight loss. These procedures don't require any incision in the skin. After the patient's under anesthesia, flexible tubes and tools are inserted through the mouth and down the throat into the stomach. The first one is the endoscopic sleeve gastroplasty. This procedure involves placing stitches in the stomach to reduce the amount of food and liquid the stomach can hold at one time. Over time, eating and drinking less helps the average person lose weight. Intragastric balloon for weight loss. In this procedure, a small balloon is placed into the stomach. The balloon is then filled with water to reduce the amount of space within the stomach so that the patient feels full, eating less food. Intragastric balloons are left in place for up to 6 months and are then removed using an endoscope. At that time, a new balloon may be replaced if they're continuing this process, or they can remove it, right, if it's determined that enough weight has been lost. Weight loss surgery includes bariatric surgery, which limits how much food can be eaten. Some procedures also limit the amount of calories and nutrients that can be absorbed. But it's important to also note that it results in nutritional and vitamin deficiencies many times. Common weight loss surgeries include, the first one we're going to talk about is adjustable gastric banding. In this surgery, an inflatable band is placed around the outside of the stomach and divides it into two pouches. Okay, so the surgeon pulls the band tight like a belt to create a narrow pathway between the two pouches. The band keeps the opening from getting bigger. Okay, so again, this is internal, inside the body, around the stomach, right? So, and then again, it provides, a small opening, right? So only so much food can get in there at one time. The next one is the gastric bypass surgery. In gastric bypass, also called the Roux-en-Y gastric bypass, the surgeon creates a small pouch at the top of the stomach. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. Food and liquid flow directly from the pouch into this part of the intestine, which literally bypasses most of the stomach and absorption, right? And finally, the next one we're going to talk about is a gastric sleeve. In this surgery, part of the stomach is removed, creating a smaller reservoir for food. It's a less complicated surgery than the gastric bypass itself, okay? Now, if we're looking at non-surgical treatments, we do have hydrogels that are available by prescription, and these edible capsules contain tiny particles that absorb water and get bigger in the stomach, thus making the patient feel full, right? So they eat less. So patients will take these hydrogels before meals, and again, it makes them feel full, and then they pass them through their intestines as stool. Another thing they might get non-surgical is a vagal nerve block. This involves implanting a device under the skin in the stomach area. The device will send electrical pulses to the abdominal vagus nerve, and that tells the brain that the stomach feels full, right? So they eat less. And then finally, the last thing that could be done is called gastric aspirate. And in this procedure, a tube is placed through the abdomen into the stomach, and a portion of the stomach contents are drained out after each meal. As nurses, we should approach patients with obesity with the same respect, courteousness, and empathetic behaviors as we do with all other patients. It's important to understand the effects of obesity on the mechanics of ventilation and circulation, as well as the pharmacokinetics and pharmacodynamics interactions, as well as skin integrity, body mechanics, mobility, and then, of course, all of these things we're going to discuss in the next slides. The main respiratory complications of obesity include a heightened demand for ventilation, an elevated work of breathing, respiratory muscle insufficiency, diminished respiratory compliance, the decreased functional residual capacity, expiratory reserve volume is less, ventilation to perfusion ratio abnormalities, hypoxemia, especially in the supine position, right? The primary reason is due to the decrease in chest wall compliance associated with the obese individual's accumulation of fat in and around the ribs, the diaphragm, and the abdomen. Patients with obesity commonly develop hypoventilation and sleep apnea syndromes, and they also have a weakened hypoxic and hypercapnic ventilation responsiveness, okay? And the final result being hypoxemia, right? Also pulmonary hypertension, and progressively worsening disability. Obese patients have increased dyspnea and decreased exercise capacity, which are both vital to the quality of life. Decreased muscle, increased joint pain, and skin friction are important determinants of decreased exercise capacity, in addition to the cardiopulmonary effects of obesity, right? Weight reduction and physical activity many times are effective means of reversing the respiratory complications of obesity. So again, if they can reduce their weight and do more activity, this will at times reverse the respiratory complications of obesity. And it's important to maintain these patients in low Fowler position to maximize chest expansion, and also supplement oxygen as ordered and as necessary, and do frequent respiratory assessments and be on the lookout for central and peripheral circulatory compromise. You want, also as a nurse, you want to ensure that the appropriate size blood pressure cuff is used for your obese patients, right? Because it's not going to be accurate if you don't. And you want to also monitor your obese patients for DVTs, or deep vein thrombosis. Remember, due to the increased risk related to decreased circulation, less activity, all of those things, right, increases their risk for DVTs. So monitor for them, assess the skin, assess for pressure injuries, and so forth. Pharmacokinetics and pharmacodynamics with obese patients, understanding that some drugs have enhanced effects while others have diminished effects with patients with obesity. Let me repeat that. Some medications will have enhanced effects and others will have diminished effects with patients with obesity. So we need to be cognizant that weight-based calculation of drug dosages for patients who are obese may need to be altered as a result of these responses within the body, right? Understanding the correlation with skin integrity and body mechanics and obesity and assessing for pressure ulcers is important. And also utilizing specific bariatric equipment for your patients when appropriate. In other words, get a bariatric hospital bed, get a bariatric wheelchair, a bariatric bedside commode, all of these things that can maintain skin integrity with your patient, okay? Again, bariatric surgery results in weight loss of anywhere from 10 to 35% of the body weight within about 1 to 3 years, helps improve comorbid conditions significantly. Enacts procedures, there's a multidisciplinary team that works with the patient. And then, if they're going to get a bariatric procedure, usually a patient has to have an BMI of 30 or above. And those patients will also need to have comorbidity, conditions in order to qualify. So not everybody qualifies, right? But if they do, then a patient could potentially lose anywhere between 10 and 35% of their body weight within 1 to 3 years. Here, again, we talked about the Roux-en-Y gastric bypass surgery. We talked about gastric banding. We talked about the sleeve. Again, it's laparoscopic, typically, so you have little tiny, very tiny scars. I mean, you can't really see them. Here's a picture of the Roux-en-Y gastric bypass, right? And it's a weight loss surgery that involves, again, creating that small pouch from the stomach and connecting the newly created pouch directly to the small intestine, right? So after gastric bypass, swallowed food will go into this small pouch of the stomach and then directly into the small intestine, thereby bypassing most of the stomach and their first section of the small intestine, thus minimizing the amount of food the patient can eat and also bypassing a large amount of the digestion and absorption from the foods that's been eaten, right? So who is this type of surgery for? In general, gastric bypass and other weight loss surgeries could be an option if the patient's body mass index or BMI is 40 or higher, extreme obese, or the BMI is 35 to 39.9, and the patient has a serious weight-related health problem, multiple, like type 2 diabetes or high blood pressure or extreme severe sleep apnea, some of those things, right? Let's see, what else do I want to say about this? Sleep apnea. In some cases, patients may qualify for certain types of weight loss surgery if their BMI is 30 or higher. Again, though, usually they'll have to have some other serious weight-related comorbidities, right? And they have to show that they tried all these different types of other diets that didn't work, and so forth, right? So it's a process, and it isn't something that gets approved quickly. It usually takes, there's counseling involved and all kinds of things. So it takes up to a year to even get approved for these types of surgeries. So here's a picture of the gastric banding that I explained, right? Again, it is adjustable and reversible, and those bands are usually made of silicone, right? They're lap bands that are placed around the stomach inside the body, right? And it reduces the stomach's capacity and slows the passage of food through the stomach, right? And so this can help retrain a patient to eat less. Here's a picture of the sleeve gastrectomy that we talked about, right? And again, it's a surgical weight loss procedure, typically performed laparoscopically, right? And about 75 to 80% of the stomach is removed. And then they build that sleeve or the curvature shaped stomach, right? The size of a banana In the biliopancreatic diversion with the duodenal switch, part of the stomach is removed. The remaining part of the stomach is connected to the lower portion of the small intestine. And this is a high-risk surgery that can cause long-term health problems because the body in these patients have a much harder time absorbing food and nutrients. So I will say that this surgery isn't one that is typically done, right? And only in certain situations. Weight loss surgery is a very effective treatment for patients who have severe obesity, right? However, patients undergoing these procedures should have a thorough preoperative evaluation to ensure the best outcomes via proper patient selection, proper patient education, and knowledge, right? And the preoperative care is extensive and thorough and can take up to a year to complete, right? We talked about that already. Bariatric surgery is a highly effective treatment for, again, severely obese. It has not only shown success in weight loss, but also helps improve metabolic comorbidities. And again, the pre-op process has several steps, and they are there on purpose to ensure that there's positive outcomes from the bariatric surgery itself, right? So there's psychological evaluation and nutritional counseling and a weight loss plan, and you got to get medical clearance to ensure that you're healthy enough for the surgery. That includes labs and electrolytes, balances and fluid status and organ functions. There's preoperative imaging and conversations about anesthesia and how that affects healing and all of those things, and education and counseling and risk and benefits and complication. Oh my gosh, can you see how extensive it is, right? And honestly, these patients are going to need lifelong follow-up. Okay. Postoperative care, right? So we want to assess to ensure the goals for recovery are met. We are going to assess for absence of any complications. We're definitely going to manage our patient's pain. They're going to be in significant pain. We're going to be monitoring their nutritional status, their fluid volume balance. We're going to try to decrease their anxiety, help improve their body images. Postoperatively, we're going to have universal supplementation with calcium and vitamin D. They are necessary after bariatric surgical procedures. Even after procedure, there's going to be a malabsorption component since food is restricted, right? The amount of food restricted. So we are going to be watching for these micronutrient deficiencies, right? And as a nurse caring for the post-op bariatric surgical patient, you should notify the surgeon of any persistent tachycardia, any sudden onset of left shoulder pain, any fevers, decreased urine output. All of these are possible symptoms of a leak, right? A leak inside that from that bariatric surgery. So you're going to let the surgeon know right away because that patient's probably going back into surgery. Severe abdominal pain and nausea with emesis of bile could be symptoms of a bowel obstruction. Really not good. Special nursing considerations for bariatric surgeries include providing wider cuffs or blood pressure checks, preventing deep vein thrombosis, and post-operation dietary education in order to accommodate, the new GI system. Also, nursing interventions include monitoring the vital signs real closely, airway patency, neurological status, managing pains, assessing the surgical site, assessing and maintaining fluid and electrolyte balance, providing a thorough report of the patient's status to the receiving nurse from the, going from PACU up to the floor, as well as giving report to any authorized family, friends, those kinds of things. Post-op complications include hemorrhaging, venous thromboembolism, it could be bioreflux, we get dumping syndrome, could be dysphagia, could be bowel or gastric obstructions, there could be postoperative bleeding, there could be at the incision site, or there could be postoperative bleeding inside the body. The bleeding could start immediately, or it could be several days after surgery, right? And postoperative bleeding can become life-threatening. So Some clinical signs of postoperative bleeding include tachycardia, right? So your heart rate goes up, but you're hypotensive, right? And again, remember the hypotension develops late because the body's able to compensate for a bit, but you get the tachycardia right away. The hypotension occurs after only a significant volume of blood has been lost, right? Patient will, though, be tachypnic, they'll be cool, their peripheral limbs will be cool to the touch, right? Because the body's going to feed the core with blood first. They may have syncope, they may have confusion, agitation, there may be swelling and or bruising at the wound site, a lot of those things, right? Also, postoperative venous thromboembolism, like a pulmonary embolism or even a deep vein thrombosis or DVT. We're going to monitor for that post-op, right? Because pooling blood can lead to clots, right? And anybody post-op is at a higher risk of getting clots in their extremities because they're less active, right? And not only that, but during surgery, the patient lies still on the operating table for an extended period of time, which puts them at higher risk for clots. And then again, we mentioned it already, but people are inactive after surgery because they're in pain, right? They're unable to walk as well. And so the blood is going to pool, and anytime it pools, it clots. So we're going to be on the increased lookout for that. So what does that look like? Well, sometimes there's no signs and symptoms of a blood clot, right? But sometimes there are. So we are going to monitor for swollen, tender areas that are painful to the touch. So if a blood clot blocks blood flow, and then that DVT breaks off and travels to the lung, your patient's going to become short of breath, like quickly, right? So 1 minute they'll be talking and fine, and then the next they're going to be short of breath. They'll have pain when breathing. They may have sudden severe chest pain, right? All of those are classic signs of a pulmonary embolism, right? A DVT that has traveled to the lung. But again, be aware that a DVT can have absolutely no signs and symptoms. Another complication might be bile reflux. That occurs when bile, remember bile is the digestive liquid that is produced by the liver, right? So when we have bile reflux, that occurs when bile digestive liquid backs up or reflexes into the stomach, and in some cases up into the esophagus, right? Bile reflux may accompany the reflux of gastric acid into your esophagus. And when this happens, you're going to have pains. You're going to have symptoms like upper abdominal pain that could be severe, frequent heartburn, a sour taste in the mouth, nausea, all of those things, right? Dumping syndrome is a condition in which food, especially food that's high in sugar, simple sugars, moves from the stomach into the small bowel too quickly after a patient eats them, right? And sometimes we refer to this as rapid gastric emptying. But dumping syndrome is a group of symptoms and includes diarrhea, nausea, feeling lightheaded, exhausted after a meal. And it's literally that rapid gastric emptying, right? And so you might have symptoms might be mild, they may be severe, right? And they do subside with a little bit of time. Although it can be alarming at first, it is not life-threatening. Okay, it can be controlled by making changes in what the patient eats, right? So we want to educate our patient not to eat too much or too many simple carbs, right? By controlling dumping syndrome, a patient will also be avoiding the foods that tend to make them gain weight as well. So it's a win-win. Okay, next is dysphagia. Remember, it's not uncommon for patients to have dysphagia after bariatric surgery, right? And also they can occur several years after surgery and are typically due to an obstruction. And this obstruction can either be mechanical or can be functional, right? And it could be caused by a non-compliant gastric pouch. And theoretically it could lead to the development of esophageal dysmotility, right? So most patients with dysphagia have an anatomical cause like a stenosis or a stricture or an ulcer, etc., right? And when there is dysphagia after gastric bypass, what we do is we go down, we do an endoscopy and look in there, right, to see exactly what's causing that obstruction. Planning and goals for the patient undergoing bariatric surgery. So post-operatively, a nurse will need to manage a patient's pain. We'll need to manage homeostatic fluid balance, right? So input's going to need to equal output. Our goal is to prevent infection, ensure that the patient adheres to their new diet, ensure that the patient is knowledgeable about vitamin supplements, knowledgeable about their need for lifelong follow-up, about how they can achieve positive body image, how they will be able to maintain normal bowel habits, right? The importance of fluids, small frequent meals that are protein focused, all of those things, right? Okay, this is the end of this chapter.